Hello people, in this video we want to look at PolyHydramnios, or you can simply say hydramnios. That will refer to PolyHydramnios itself. Okay, so basically what is happening here, this is basically coming under amniotic fluid disorder. In PolyHydramnios or hydramnios there is more amniotic fluid, okay, and then you have oligohydramnios where there is less amniotic fluid. Did you understand, people? So basically you have two conditions here. Middle one is normal and smiling. Look at this guy. This guy is normal and smiling in the middle. Okay, he has around 1000 ml of amniotic fluid to dance, right? So he is very happy. But this guy in the beginning, he has more fluid and still he's sad, right? So this is PolyHydramnios, okay, hydramnios, okay. And then this side, he has less fluid and still he is unhappy. Right, this is oligohydramnios. So how much does this guy has? The less guy has less than 200 ml. So less than 200 ml is oligohydramnios. Greater than 2000 ml is polyhydramnios. This is one criteria. There's another criteria which says if you measure the largest vertical pocket LVP or the deepest vertical pocket. Okay, you measure the vertical pocket, that's what VP, vertical pocket, largest, deepest, whatever. If it is 8 centimeters or more, then this is polyhydramnios. If it is less than 2 centimeter or less, it is oligohydramnios. So this much did you understand, people? There is, how do you calculate this? There's one more thing, right? Amniotic fluid index. So you have to calculate amniotic fluid index. So this is amniotic fluid index. Here you will take 4 measurements, not like this one, largest, deep and all. You'll take 4 measurements, okay? So 4 measurements you will take at 4 places and then you'll add them up. So you will get around 10 to 15 in a normal guy. So in a polyhydramnios, what will you get? You will get greater number, greater than 24. And in a oligohydramnios, you will get less than 5. Is it too much to remember, people? Look at this, okay? We'll just write some numbers here. 8, 24, 2, 5. Here it's 2 liters and 200 ml. I think that is fine, right? You have to remember these values, okay? So this is the amniotic fluid index. And this one is for the single, that largest or deepest pocket, okay, vertical pocket. So let's go back here. So in this video, what do we want to look at, people? So we are looking at what in this video? Polyhydramnios, okay. So polyhydramnios or hydramnios where the liquor exceeds how much? Greater than 2 liters. The largest vertical pocket greater than 8 centimeter or the AFI greater than 24 is the cutoff, okay. This is the definition of polyhydramnios. So you should write the definition of polyhydramnios, very important, okay. And in this you have 2 types, chronic and acute. We'll come to this. Oligohydramnios means what? Less than 200, and you will see that LVP is less than 2 centimeter, less than or equal to kind of, you can say, and AFI is less than 5 centimeter. Okay, people? Good, no? You have understood everything now. Now, what do we want to focus on? We want to focus only on polyhydramnios or hydramnios. So in this, you can see that there are 2 varieties. You have chronic, which is the most common. So it is insidious in onset, slowly, weeks together it will take, and finally this lady will have a huge belly. Acute means it is sudden in onset. This is not very common, but this can happen like sudden. Imagine suddenly she has so much amniotic fluid that can happen because of monozygotic twins with twin-to-twin transfusion syndrome, which is not so good, isn't it? One twin sucking out from the other twin. Chorioangioma of the placenta. What is this chorioangioma? So this chorioangioma is a benign tumor of placenta and it is nothing so scary, looks like. It's a most common benign non-trophoblastic tumor of the placenta, it says. Anyways, but most of these sudden polyhydramnios will end up in spontaneous, mostly they'll end up in spontaneous abortion, they're saying. Okay, so basically we will focus on, what will we focus on? Shall we focus on chronic polyhydramnios? You have understood acute is like not so common, right? Anyway, so let us go to chronic, most common. In this, it is onset is what? Insidious. It is gradual in onset, okay. So this condition is more common in multipara than primary gravidae. That means in a multiparous woman, she has already, the uterus is stretched. For any reason like that, there is more fluid, is it? So it is more common in multiparous women, okay. Now, what are the causes of polyhydramnios? This is very important to understand why, and mostly we will be considering the chronic one, let us say. There is some problem with the fetus, which is really not sounding good now. Anencephaly, spina bifida, esophageal or duodenal atresia, facial clefts and neck masses, Hydrops fetalis, that is, this is RH isoimmunization, or this is because of jaundice, too much of bilirubin, Aneuploidy, okay, some chromosomal abnormality is there in the fetus. So that is why there can be polyhydramnios. So what they are thinking is, this baby is making a lot of urine, right? Or it is not swallowing the liquor. So either of it has stopped, either the absorption has stopped or the production is more, isn't it? So basically they are blaming this fetal antidiuretic hormone, which is leading to excessive urination. The baby is urinating a lot. The baby has some absent swallowing reflex. It doesn't know that it has to swallow at all. Or one more cause they are saying is, for the production is that there is transudation from the exposed meninges in anencephaly. So just mention that there is more production either via urination or from these exposed meninges, or this baby really does not know to swallow. There is some problem with the swallowing. There is prevention of the swallowing. Either it doesn't have a swallowing reflex, or there is prevention of the swallowing, or there is some interfering with the normal swallowing. Now let us move on to placenta. Now what will the placenta abnormality be? Chorioangioma. This is what they told you even in the acute condition. So what is happening here? There's a tumor, right? And what is it doing? Increased transudation. That's what they're saying. Again, the production is more here. Now, what happens in multiple pregnancy? We already told you, especially if there is twin-to-twin transfusion syndrome, right? That is a big problem. Now, coming to these two can be because of, these two can lead to acute acute what? Polyhydramnios. Now, let's come to mother. Can we also blame something in the mother? Yes. In the mother, if there is diabetes, there is possibility that she is having polyhydramnios, okay? Then, why does this happen? Why does this diabetes lead to polyhydramnios? There is raised maternal blood sugar. So the fetal blood sugar increases. So fetal diuresis, hydramnios. So it's the same thing. In diabetes, you have polyuria, polydipsia, right? Something like that. Now, what if there is maternal renal issue? Then why is amniotic fluid more? Edema of the placenta, increase in transudation. Again, this is because of increase in transudation. Okay. What did they say here? Diabetes, polyuria of baby. Okay. So, raised fetal blood sugar, fetal diuresis. Raised blood sugar of baby also. And so baby will urinate. So this is the cause for this. So we'll just add the cause. Now coming to what else? That's it. For maternal, only two things they have given. And then finally, you always write one idiopathic. Do not forget. Idiopathic can be there. You do not know the cause, and these people will have polyhydramnios. Yay, people, you have completed the causes of polyhydramnios. Now let us proceed now. What should we look at next? The types of polyhydramnios, or you can just say hydramnios, because that is more common, looks like, right? Is this spelling correct? Why can't it recognize hydramnios correctly, right? Okay, the types of hydramnios, types. So you can have mild, moderate, severe. So beyond 8, definitely poly, right? So if it is 8 to 11, 12 to 15, greater than 16, severe. Okay, we'll proceed now. Chronic polyhydramnios, what is there here? The symptoms that she will come with. Sometimes it can happen that the patient is asymptomatic. The patient is not very much inconvenienced. Okay, she's fine. She can have dyspnea, respiratory problems, because, you know, she has a huge abdomen, isn't it? And she will have palpitations, edema of the legs. She's having fluid retention. Varicosities in the leg or vulva, and hemorrhoids. Okay, so varicose veins, right? That's what they're saying. Hemorrhoids. Again, hemorrhoids is veins, right? Your anus around that. So basically the pressure that it is putting on the whole body. What are the signs that you will see? The patient may be in dyspneic state in the lying down position. So she's having dyspnea even at a sitting position. Okay, she's even at rest. How's it going, people? What are we looking at? The clinical features. Imagine you have a huge abdomen, how it will feel, right? So then you will see evidence of PreEclampsia may be present. So PreEclampsia can be there in these people, which they did not mention in the cause, right? In the cause of PolyHydramnios, nowhere they mentioned eclampsia, but the cardiac being hypertension. Okay, anyways, let's move on. Now let us look at the abdominal examination. What are you seeing in the abdominal examination? She seems to have a huge enlarged globular abdomen with flanks also full. The skin is tensed, shiny with large striae, right? Because it's so stretched, the skin will be looking shiny. Palpation. When you palpate it, what will you feel? The height of uterus will be more than the period of amenorrhea. Of course, the uterus is going to be huge. So if you want to expect a period of gestation, you expect it somewhere here, you will feel the uterus much higher. The girth of the abdomen is more. Yes, we already know this. Fluid thrill you can get. Yes, because it's full of fluid. Fetal parts cannot be well defined. So you cannot feel the fetus. Why? Because the abdomen is so distant, there's so much of liquor. External ballotment can be elicited more easily. So external ballotment means you can check the movement, right? So how ballotable it is, right? That is what they're saying. So you can check the movement of the baby. Here they're not talking about the head, right? External ballotment can be elicited more easily. Understand that they are saying this is external. See, the hands are outside only. Internal means you'll have to go inside the vagina, I think. Right? Then coming to auscultation, the fetal heart sound is not heard distinctly, although its presence can be picked up by a Doppler ultrasound. So you'll need a Doppler ultrasound to pick up the fetal heart sounds. If you use stethoscope and all, you cannot hear the fetal heart sound. Okay? Because there is so much fluid, you can understand that, right? So this is abdominal examination. So what did you learn, guys? You learned that in PolyHydramnios how to do abdominal examination. Okay, that's great. Now let's move on to internal examination. So what will happen when you check the cervix and all, you will see that the cervix has been pulled up, okay, partially, and at times it may be there or all the time like that. It may be partially taken up or at times it can be up, okay, the cervix. It can be dilated, the cervix can be dilated, and you can actually possibly put a fingertip here and feel the bulging membranes. I'm not sure if they do this because you should not cause more harm, right? Anyways, guys, let us look at the investigations. So basically, you will see that you can do an ultrasound in these people and you can calculate a lot of things about the amniotic fluid, and you can check if the fetus has any problems, if it is twins, etc. All that you know. Blood you will check for, what will you check for? The RH grouping, right? Mother and the child. Then you will check the blood glucose levels, postprandial, basically glucose tolerance test to know whether she has diabetes. And then coming to AlphaFetoprotein, estimation of AlphaFetoprotein. Basically this is going to be important. AlphaFetoprotein, what will happen if it is more elevated means there is neural tube defect. So that is why all that extra fluid is getting produced, transudated. They say open neural tube defect. That's why here they told you Anencephaly, open spina bifida, all these are open. Okay. So that's what you should understand. Anencephaly, then this spina bifida, all these are open. So they're checking what? AlphaFetoprotein. Where are we? We are in investigation, right? Okay. We're done with investigation, people. Great. Now let us move on to what? Good. You have finished what? Investigations for PolyHydramnios. Very good, people. Now let's move on to differential diagnosis of twins. Yeah, you should check whether these people have twins. That's why they are having such a huge uterus. Pregnancy with huge ovarian cyst. This could be another thing, that there is a huge ovarian cyst in that lady. Okay. So where is ovarian cyst? Here are the ovaries, right? Ovarian cyst will be huge. It will be pushing the uterus. So what will happen? The cervix to be pushed down into the pelvis. The gravid uterus can be felt separate from the cyst. Okay. So anyways, you'll have to consider that also. Maternal ascites, that means she is having fluid retention. So it is not the uterus, it's something around that is maternal abdomen, peritoneal cavity, right? So she is having fluid elsewhere, not the uterus, not the amniotic sac, okay? So here what will happen, there will be shifting dullness, all that you have done, abdominal examination, remember? So you can do an ultrasound or a X-ray. X-ray is not supposed to be done in pregnant women. Why did the textbook say this? So you just do an sonography to rule out maternal ascites, okay? Now let us look at the complications that can happen, guys, because of polyhydramnios for the mother. What do you think the complications will be for the mother? During pregnancy, she'll have more chance of preeclampsia, right? She'll have malpresentation of the fetus, floating head. She can go into premature rupture of membrane, you can understand, right? She's going to go into preterm labor. And imagine if there is sudden escape of this liqor amni, okay, the liquor is suddenly lost, let us say. What is this? There will be decrease in the surface area of the emptying uterus beneath the placenta, and there can be accidental hemorrhage, okay, because of the sudden escape of liquor amni, okay. In labor, what will happen? Actually, we told you this already. She can go into early rupture of membrane. There can be cord prolapse. Imagine so much fluid, the cord can just come out, right? Cord prolapse can happen. Uterine inertia. So what do you mean by uterine inertia? Inertia is more like something that is in a position, stays in that position, something like that, right? So it will fail to contract. That's what they are saying. It will fail to contract. You want it to contract to push the baby out. Increased operative delivery, so you may have to use forceps or vacuum because of malpresentation, okay? There can be a retained placenta, there can be postpartum hemorrhage, which can be more, and shock, okay? Why does the postpartum hemorrhage happen? Because of uterine atony. Again, it's very flabby, the uterus, right? It has to contract, which it's not. Puerperium. What happens after the delivery of the baby? Here we are, in case you're not able to see. So there can be subinvolution. That means the uterus, it has to come back, right, to its position, but it is not. So there is subinvolution. There is morbidity because of infection. Mother is going to get infection because you had to put forceps or vacuum. So because there was operative interference, and she also had postpartum hemorrhage, etc. So she can have infection, okay. So these are all the problems which happen for the mother. But I think here, more concerned they are about the fetus, okay. What happens to the fetus? It can die. Perinatal mortality is more, okay. The baby can come out soon, means what will happen? Prematurity, and mostly the cause of PH is congenital anomaly. So even if it comes out, it could have some problem. And because of this excess fluid, it can have cord prolapse, right? Or hydrops fetalis, where there's a lot of fluid buildup inside the baby. And again, the baby will have to endure all the forceps and the vacuum, etc. and the accidental hemorrhage. It has to survive all these to come into this world. So these are the complications of, you completed the complications of polyhydramnios, guys. Very good. Now let's move on. Now let us look at the management of polyhydramnios. So are you ready? So how will you manage this person? So you will hospitalize this person. If they have polyhydramnios, you do not send them home, you hospitalize them, and then you do all the blood tests required. You will check the glucose tolerance test, you'll check the postprandial blood sugar, you'll check her for the last 3 months of glycosylated hemoglobin. Then you will check for Rh isoimmunization, blood grouping. Then you will check for fetal anomalies, all that ultrasound you will do, genetic check you can do. Then you will check if she has infections, right? And then you will check for red cell antibodies, okay? So all this you will check, all checks you will do. And then you will say that the baby is fine, okay? There are no problems because of the fetus. That means you have to try to save now, right? So what will you do here? Go down here. So, is the mother responding to treatment? Yes. Then you continue the pregnancy and manage any complicating factor, like all those complicating factor, premature rupture of membrane. You should be ready to manage all that, and then you will deliver at term. However, if the mother is in distress, okay, and then she's less than 37 weeks, then you will have to try to reduce the amniotic fluid, Okay, AmnioReduction you're going to do, and then you're going to deliver. Okay, so you're going to amnio-reduce till the baby becomes mature. Okay, and then when you're doing delivery, you should check for PPH, and you have to check the neonate for malformations. Guys, are you understanding? Now let us say the mother is in distress and she's anyways term. Okay, so you can do AmnioReduction, you can correct the lie of the baby if needed, right? That is, you can make it cephalic presentation, is it longitudinal lie, etc. Then you will give oxytocin drip, and you are going to do controlled rupture of membranes. What is ARM? Artificial rupture of membrane, and deliver the baby. Now let us say the baby is not fine. Let's use a red here. Baby is not fine. Now what to do? You'll have to refer to a MFMU. What is MFMU? Maternal and Fetal Medicine Unit. Maternal and Fetal Medicine Unit. Some special unit you will have to send them. And then they are given an option of terminating the pregnancy or continuing. And based on that, they will decide what to do. Okay. So this is the management of PolyHydramnios. So here you have to write a few generic terms like antenatal care. So you should monitor her very carefully. She should come for a lot of visits. You can order some bed rest if required, because she's having a very distended abdomen, right? Diuretics don't help much, they are saying. And whether it is mild, moderate or severe, based on that you'll have to treat. Okay. There is one drug here called as Sulindac. Okay, Sulindac. Okay, this one has been found to be most effective. It has been found to decrease amniotic fluid as it reduces fetal urine output. Okay, this reduces fetal urine output. So you have to know what the cause is, and based on that you will have to decide this drug, right? Fetal urine output. It reduces the fetal urine output. Sulindac. You have to say that some few times so that you can remember it. Sulindac. Okay. So this is what you have learned about management of PolyHydramnios. Okay. So in this video you have looked at PolyHydramnios or hydramnios, both the acute and the chronic condition we have looked at. In the next video we will look at oligohydramnios. Okay people. Bye bye.